Hi guys, what's up? In this video, I'm gonna be going through the angina pectoris or simply angina. So first of all, angina pectoris refers to discomfort of the chest or what we call strangling of the chest. Okay, so it is a symptom complex caused by transient myocardial ischemia, which occurs whenever there is an imbalance between myocardial oxygen supply and demand. Well, let's focus on pathogenesis of angina pectoris. Atherosclerosis, by far the most common cause of angina pectoris. Angina also occur in aortic valve disease and what we call hypertrophic cardiomyopathy, and when the coronary arteries are involved with aortitis or vasculitis. So this is the first one, atherosclerosis. The second one, coronary artery spasm. Angina may result from vasospasm of the coronary arteries. This may coexist with atherosclerosis, especially in unstable angina. So this may sometimes known as variant angina when it's accompanied by transient ST elevation on ECG. It's termed as transmetal angina. First one, atherosclerosis. The second one, coronary artery spasm. The third one, syndrome X. The fourth one, other causes. Angina may association with aortic stenosis, hypertrophic obstructive cardiomyopathy, and what we call aortic. Well, let's focus on factors. For what? Factors influencing myocardial oxygen supply and demand. So here we have factors for oxygen demand or cardiac work such as heart rate, blood pressure, myocardial contractility, left ventricular hypertrophy, and valve disease. On the other hand, we have for oxygen supply, coronary blood flow, we have duration of diastole, coronary perfusion pressure, coronary vasomotor tone, and oxygenation. So coronary blood flow occurs mainly in that. Let's focus on clinical feature. Clinical feature. The history is the most important factor in making the diagnosis. Stable angina is characterized by central chest pain, discomfort, or breathlessness that is predictable, precipitated by exertion or other forms of stress, and relieved by rest. So here we have activities precipitating angina. We have common and uncommon. Common such as physical exertion, cold exposure, heavy meal, and intense emotion. While on the other hand, we have uncommon like vivid dream or what we call nocturnal. And some patients find discomfort comes when they start walking, and then later it doesn't return despite greater effort. So it belongs to warm-up. And then we have Canadian Cardiovascular Society score system, CCS. It's common used to gauge the severity of angina, which is class 1, class 2, class 3, and class. So in class 1, those with angina only during strenuous or prolonged physical activity. Class 2, those with a slight limitation, and angina only during vigorous physical activity. Class 3, moderate limitation. Angina where symptoms occur everyday activity. Class 4, severe limitation and inability to perform. So physical examination is frequently unremarkable but should include a careful search for valve disease, particularly aorta, and important risk factors such as hypertension and diabetes mellitus, and what we call other manifestation of arterial disease such as peripheral vascular disease, peripheral or what you call carotid roots, and the last one, search for left ventricular dysfunction such as cardiomyopathy. So now let's jump to the investigation of the patient with angina pectoris. So stress testing and non-invasive imaging are advisable for the patient with potentially candidate for revascular. In the investigation, we can say first of all clinical consultation, history and examination, and then blood test, ECG, chest X-ray, and echo, and then consider exercise, ECG, and then is it clear diagnosis of angina, yes or no? If it's yes, okay, obstructive coronary artery disease, preventive therapy, anti-anginal therapy, and then consider invasive coronary angiography plus minus revascularization. If it's not, okay, non-anginal chest pain and normal ECG, no or yes. If it's yes, okay, no coronary artery disease, and consider alternative diagnosis. If it's not, okay, send for CT scan and coronary angiography. Then we have three choices. It's either no coronary artery disease or non-obstructive coronary artery disease, which then jump to the preventive therapy, or obstructive coronary artery disease and then preventive therapy, anti-anginal therapy, and considering invasive coronary. And about ECG is what we call downsloping ST segment depression is of 1 millimeter or more is indicated of ischemia, while upsloping ST depression is less specific. Why? Because it may occur with digoxin therapy, left ventricular hypertrophy, and bundle branch block. While about the coronary angiography provides detailed anatomical information about the extent and nature of coronary. So now, what about management? The principle of management involve, first one, a careful assessment of extent and severity of arterial disease. This is the first one. The second one, advice on smoking cessation. The third one, identification and treatment of risk factors. The fourth one, introduction of drug treatment for symptom control. Okay. The fifth one, identification of high-risk patient for treatment to improve life expectancy. Okay, all patients with angina secondary to coronary artery disease should receive antiplatelet therapy. I mean, low dose 75 milligram aspirin should be prescribed for all patients. Okay, and clopidogrel 75 milligram daily is prescribed as an equal effective alternative if aspirin causes dyspepsia or other side effect. And also the patient should be prescribed the statin even if the cholesterol level is. So in the management we have anti-anginal drug therapy and non-pharmacological treatment. In the anti-anginal drug therapy, the aim is to control symptoms, okay? And there's groups of the drug that used for prevent and treatment of angina, such as nitrates, beta blocker, calcium channel antagonists, potassium channel activators, and ranolazine, okay? So in the nitrates, act directly on vascular smooth muscle, okay, due to venous or arterial dilatation, while beta blocker and calcium channel antagonist result in lower myocardial oxygen demand by reducing heart rate, blood pressure, and myocardial contractility, while the potassium channel activators, nicorandil 10 to 13 milligram twice daily orally, is currently available for clinic. So on the other hand, as I said, we have non-pharmacological treatment such as PCI, percutaneous coronary intervention, and coronary artery bypass graft. So what about PCI? This can be combined with the deployment of coronary stent, okay? And also treatment with PCI, percutaneous coronary intervention, often provides excellent symptom control, but it doesn't improve survival patient, especially with the chronic stable angina. Okay, so it's mainly used in single or two vessel disease. Well, the main acute complication of PCI is occlusion of the target vessels or the side branches by thrombus and a consequence myocardial damage. Well, the main long-term complication of PCI is restenosis. Okay, restenosis. So in up to 1/3 of the cases, well, due to combination of recoil elastin and smooth muscle proliferation that tends to occur within 3 months. So that's all about PCI. So what about coronary artery bypass graft? We have internal mammary artery, radial artery, or reversal segmental of the patient's own saphenous vein can be used for bypass the coronary artery stenosis. Okay, so artery graft have a much better long-term patency rate than others artery. Okay, so aspirin 75 milligram to 150 milligram daily and clopidogrel 75 milligram daily both improve graft patency, so one or other should be prescribed. Okay, and the last thing is about complication. Neurological complication are common with 1 to 5% of peri-operation stroke. That's all about the anginal pectoris. Hope you get a benefit from this video. Thanks for watching.